And next I have the great pleasure of inviting one of my colleagues here. Stephen Bromhall is the General Manager of GE Healthcare's Enterprise Digital Solutions business in Northern Europe region. And Stephen has an extensive experience in healthcare IT, over 20 years of it. And today he will present actually on behalf of one of our customers, a large NHS radiology consortium called emrad, on how they use data analytics to drive clinical, financial and operational outcomes. So please welcome Stephen.
Good morning, just about. Interesting, I'm going to follow on from Professor Sheesh about collaboration. It's going to be the key theme of what's driven this particular customer of GE and the story. I'm going to rattle through very early why and then go into what the data has delivered to the outcome for a high proportion of the UK population. So in the context, this is my customer. The 30 million is a comment that Andrew would say on any stage that we were on together. The procurement alone, before it even started on the business case, saved 30 million from where they were. So what did that mean? How did that happen? So 7 trusts in the UK NHS came together. They wanted to collaborate. They were serving 4.6 million patients, 11 hospitals, 2 million studies a year. In radiology, we all know, huge shortage of radiologists. The data sat in silos. That data also kind of enabled lack of specialist care where it was needed. And also there was a huge amount of escalation in outsourced reporting. So the kind of the view was each one of these hospitals had their own, did everything themselves. They didn't share, didn't collaborate. There was nothing in there that could be consumed later. So if I was a patient that got imaged at one of the hospitals, that image couldn't actually get to another hospital. So I was re-imaged. And we all know what that could mean in terms of radiation exposure. So really what kind of drove the objectives of this initiative was really to increase the quality and the satisfaction. Also the productivity, and data drove productivity, and this is where we are now, and we'll go into that as we get through the speech. Reducing the waiting times, so basically not having to move patients around. Also cost, huge cost driver. And one thing that we think about here, I talk about the analysing of the transfer costs. A lot of patients get manually moved. They go into one hospital, or used to go into one hospital. They realised that there was perhaps a paediatric admission. They didn't have a paediatric on call because it was after 5 o'clock. So the patient got put in an ambulance and then moved somewhere else. Now the system would image that particular paediatric patient, and the images would be available to the paediatric team at another hospital that was connected in their environment. The UK system is very old compared to what I see in the Nordic countries. We don't have a national register of imaging. So effectively, if people get moved manually, images get moved either in CDs. Often people would go into, as a patient, would end up in an ambulance with a CD on their chest, going somewhere else. Now, with what we've produced together, images get to the new hospital before the patient, which is very unique in our care setting. We also wanted to look at a solution together that would give huge availability. So this wasn't about, I started off as effectively a radiology system that was sitting in a silo, wanted it always available, wanted it in the cloud. This was a cloud delivered model, private cloud. They wanted a disaster recovery that would be up again in 15 minutes from failing over with 0 data loss. So, and also everyone in the trust wanted a business continuity solution. Didn't want to rely on the way they'd always done it. This was about new world thinking. Just kind of from the customer's perspective, why GE? They chose GE because GE was their partner. The GE would invest in this solution together from our industry knowledge. It was about expertise and outcomes, and we would stand up to our commitments. So to say, at the centre, everything is centred around a VNA. It was one virtual archive where all data sits. So whether you're in Trust 1 or Trust 7, or you want to share with an external trust, it sits in one virtual clinical archive that takes radiology and other ology data. Around the edge of that is the feeding platform, so the radiology information system, the orders, the reporting. with viewers independent of what type of ology, and the ability with our collaboration platform to collaborate with external partners, Eccentricity 360. And all of that feeds the data points, so the operational analytics, the qualitative analytics and the financials. So I'm now going to kind of step into these. Our analytics is part of our smart connected solutions portfolio, which is around collaboration and the outcome, clinical need, clearly, but the byproduct of our solutions give us the ability to drive change, drive results. I kind of would say from GE, we would always talk about our Edison analytics suite, where all of our analytics products come together. If you could step by our booth, you can see some of this in real time. So we go from the data to the collaboration to the analytics. So in terms of what we've done in analytics, which is kind of the key thing following on from Professor Shish's view, is that we've brought together all the information into one place. It's real-time analytics, it's historic analytics, so we're using it for both business intelligence, also how does that spurn the future use of AI. An element of the program that we've done with the back-end archive is actually using it to test real-life data, testing of artificial intelligence in the analytics space. A major program in the UK where emrad, on behalf of the Department of Health, are actually making data available for testing SME analytics as part of a service to the UK government. But what we've really shown from the analytics is about what we can get from it. And I'm going to go into the kind of this removing Andrew's builds. So we've kind of come from looking at it from how do we drive the service? So what's the capacity that we've got and how much demand are we getting? And that's really enabled them to look at how variations are covered. The financial effect and efficiency. So if you're the radiology service manager or you're the chief operating officer, you really want to know, how good are my team? Have I got outliers in my team? And their teams every day have dashboards that come up on their screens, almost pushed to them at the chief operating officer level. And this is the data they're driving. They're looking for these outlying dots in at the bottom of the outside the demographic area. They're looking at how they bill back to the UK government, making sure that they're billing by the right reporter using the right codes, making sure that the productivity and the trends they're seeing across the estate are real. They're using the data that comes out to actually give the statutory reports back to the UK government. I kind of would say the capacity and demand, if I was to drill in it a little bit further, so it's not come out particularly well on the screens, but what we're kind of saying is comparing how is capacity against demand fulfilling itself. So what's sitting there from a reporter's perspective? Pending reports, this is where a real key and turnaround times. So how quickly are reports being turned around? Is there a gap? Why is there a gap? The data is being used to drill real time and to look at the patient flow. An element of this going forward, which we're working on together, is actually predicting the cancer workflow, to actually using these dashboards to alert when a turnaround time is going to be missed. So under the UK rules, if it's a 62-day target from starting to go into treatments, if that's not going to flag, this actually flags and tells the true story and enables patients to be picked up and prioritised. Also looking at unreported details. So really it's using data to drill into the back end of the systems real time and actually pull out this kind of decision support and decision demand. In terms of the financial billing, we're a provided healthcare system. However, reports need to be publicised. The financials need to be publicised back to the Department for reimbursement. Again, it has to go out in a statutory format. The platform that we've provided gives that data point, gives that output, gives that export perspective. Again, it's down to how quickly things are done. From the team at Emrad, they've got a business intelligence team. They can't do their jobs without this. They've gone from a team that was 3 per trust, so 21 analysts doing this. They're now down to a team of 3 using this and creating all the statutory reports that they need, plus ad hoc development. So really it's driven a huge amount of cost out of their system. Also look at the productivity. So we're now using it to look at what can be auto-reported, why it can be reported, unmet demand. So we're really focusing on using technology because we've got a global shortage of radiologists. We've got a global shortage of acute radiologists in certain subsectors, and how we can actually make a huge difference in terms of using what we've got in a better way. We also drive down into, if there's any radiologists in the room, it's not shared out too widely, but inside all of the trusts, they actually look at radiology performance, or radiography reporting, to actually compare radiologists against radiologists. Well, how long is it going to take to do a CT head? How long is it going to take to do a certain type of study? And not to drive outcome and change against performance about is there a training issue, is it a study type? Was the image acquired incorrectly? Did it take longer to report because it was on the wrong dose contrast? This is the data that's actually coming out. And also to look at perhaps where equipment isn't performing. So does the radiologist actually have to work harder because the CT or the MR or the plain film hasn't delivered exactly what was ordered? So there's really to drive analytics to drive the way impact and change in effect. Driving down to exams, these are kind of real-life dashboards that come out from the system every day, which is looking at the turnaround times from comparing historic to today. Also, there's an area of machine learning been built in to actually predict. We know what's coming in terms of clinics and outpatients, actually using the analytics, almost using a mini version of AI to actually say what demand do we think we're going to need based on our patient lists that's coming through. So this is kind of real-time analytics to drive real-time outcomes. And we see here where we got these orange and red dots. These are kind of outliers, which is what the business intelligence team go to drill into. So if this was a live dashboard, we could drill into this and actually pull out why we've got outliers. So it's actually being used real time to drive the impact and efficiency. So from an outcomes perspective, what did this really mean to the customer? And this is their story, it's not a GE story. I'll kind of step back from the screen, but in terms of the collaboration, there's some numbers that the Emrad team would always talk about, which is about a simple one, about using a collaboration tool. They say £300,000 a year on postage costs alone. Doesn't seem particularly much, but I put that into a high piece of equipment. So it's kind of getting towards the acquisition of a CT scanner. That's avoidable costs that is not needed. It can be then thrown into patient care equipment, more radiologists, more clinicians. Reduction in terms of moving information, getting more from activity. We've got a medical legal kind of growing need of people wanting to sue the NHS for malpractice. And this is actually, there's a regulation. This enables the client to be much more aligned to that. The big driver around analytics from a radiology perspective is stopping outsourcing. So as part of this, instead of outsourcing huge amounts of exams per year, you have to use this tool to actually drive insourcing, reduce the outsourcing by 30%. And also aligning all the hospitals, because they are unique hospitals with their own budgets, being able to use the tool to drive capacity to the outsourcing companies to drive down cost per exam for outsourcing costs. And last year was able to by tariff alignment between the organisations take 100k out just on looking at who was outsourcing to what, for who and how much. So kind of some soft numbers. Emrad won't declare how much they do outsource, because it's quite a political viewpoint, but it's in the millions, so they won't actually declare that particular number, but it's kind of there. And I think what they would all say is, by having this vendor-neutral archive with everything in, with the data, the images, the information, it's enabled them to improve their care, improve the way that they deliver their service. Simon Harris, who's one of their program directors on some of their programs, he spoke at a conference I was at last week, and he quantified this up, that they say 300k purely in postage costs, which was, I think it was a horrific kind of response from the audience to say, 300k in postage costs, why are we talking about that? And then we talk about the acute system we're in, lack of funding, it meant we could actually drive much more effect and efficiency. And that's purely a UK phenomenon, of course. I could walk through some kind of efficiency charts, but I think what I've tried to take through this conversation, which is by collaborating and combining data, the outcomes have been quantifiable in terms of patient care, clearly, which is what we're all here for, and how we deliver faster benefits. But as a byproduct, and it really is a byproduct, the data has enabled us to take cost out of the system. The other area that I've just kind of would point out, really from a centricity of data, is about moving information at speed and pace to enable the outcomes to be delivered. That we no longer have to think about how a patient's information is going to get retrieved elsewhere. It's real time. The information's there immediately after acquisition on effectively a DICOM device. It's actually in the archive. It's available to be analysed, and the data there can then be combined with other impacts and outcomes and effects. So just to summarise, effectively, from a client's perspective, the image quality and satisfaction, they went into a collaborative environment to share data, to share information, to enable better outcome to the patients. Enabled productivity, enabled cost to be driven out from a solution, and drove effectively from a transfer perspective and efficiency. I think this is what I think Andrew would say if he was speaking here. The improved efficiency is one of the key things that they would say is the 85% quantifiable with the data, because they couldn't quantify it before. Now the systems are telling them they are getting an 85% improvement in their turnaround times. Some hospitals in the consortium have 0 waiting lists for reporting. When we started, these hospitals would typically have tens of thousands, and in one case 35,000 reports in backlog to be reported. That particular organisation has got 0 delays on their turnarounds. So I think from that will be my close. Thank you for listening.